Okay, so the role of the clinician. So it should be a clinician doing the BSSA. Doesn't have to be a mental health clinician. And so we're ideally it is a mental health clinician. If you have one, if you have a social worker who's available, if you have any other mental health clinician, that might be the easiest person to utilize for the brief suicide safety assessment. However, and I've seen all kinds of other clinicians do the BSSA. Really, you just need a trained clinician to do this. So there are two tools right now that can be used to do the BSSA. I'm going to train on the Ask Brief Suicide Safety Assessment. Some people, because this is in your EHR, another tool that is commonly used is the Columbia, but we're going to train on the Ask. Okay, so how do you introduce a BSSA? Remember, a patient just screened positive. So the person doing the BSSA will come in and say, I want to follow up. Now, and by the way, I just want to reiterate this. The ask four or five questions, they have to be asked exactly as they're written because each one was tested through research. This script that I'm showing you, and even the script for the BSSA, that you can make your own. If you don't want to say this, I want to follow up on your screening response, on your responses to the suicide risk screening questions. Thank you for letting me know that you're having these thoughts, as these can be hard things to talk about. I need to ask you a few more questions. That's just suggestion. If you think of something that's easier for you or you feel like is better, please use your own script. You could start with this, and then usually what happens is it becomes your own. But the main points here is you want to acknowledge that these are hard things to talk about. And so you want to say, have some way to praise the patient for talking about them. So there's different versions of the BSSA. This is the adult outpatient version. So the first thing is, I just went over that. The next thing is the actual assessment, and how it is broken up is reminding you to ask the things that are important, right? So the first thing is frequency of thoughts. How often are they thinking about suicide, right? Because it's very different if someone may have screened non-acute positive and they say maybe every time I'm in pain, I think about it, so maybe 1 or 2 times a month. That is less worrisome than the person who's thinking about it every day, multiple times a day, right? I'm also going to tell you that and I'm not telling you this to frustrate you, but this is just the truth, is that there's no exact formula for doing this kind of assessment and what you do next. This is about judgment. And people want to force a formula and say, no, we need a formula. And I wish I could give you a formula, but because every person is different, every suicide presentation is different. And so you're going to use these questions, these prompts, to make the best clinical decision you can. It's not going to be perfect. You're doing the best you can with something that's really complicated, and it's different every time. But I'm going to give you what the general things are that make someone at higher risk. So frequency of thoughts. And then the BSSA gives you some questions, but you can ask anything you want. How often are you thinking of this? When was the last time you thought about it? So that's different if the patient says, I'm thinking about it right now. I thought about it this morning. I thought about it yesterday. That's different than a few months ago, I was thinking about it. And then you can say, while you're asking these questions about frequency, are you having thoughts of killing yourself right now? That is question 5, but it's okay for you to ask it again. And it's okay to be repeating things that even the tool, because sometimes people answer one way on the tool, and then when someone's sitting down talking with them, they say different things. So again, if they say yes to they're thinking of it right now, then this person is going to need a full mental health evaluation. If you find that out along the way, you can stop and order them a full mental health evaluation, however you do that, because you know now that you got to that point. That's what this tool is meant to help you decide. Is this an emergency? Is this an outpatient referral, or they can wait and get help, but it's not an emergency, or nothing more at this time? That's what you're trying to decide. And if you have any questions about this, please pop in. And again, Debbie, I can't see the chat, so you can let me know. The next area is a suicide plan, right? So you want to see if you were going to kill yourself, do you have a plan to kill yourself? And if they say, and even if they're not thinking about it, I always ask plan, and I always ask it twice. And I'll give you an example. So do you have a plan to kill yourself? Sometimes people, most of the time, if they have a plan, they'll tell you what it is right then and there. What is your plan? And if they say, you know what, I don't have a plan, then I ask again, right? Because I've gotten a lot of answers when I ask twice. Then I say, well, if you were gonna kill yourself, how would you do it? And then sometimes I hear something like, well, I guess I would use pills, or and then what I listen for here is how detailed is this plan, right? Because sometimes I hear, my husband has a loaded gun in the nightstand, and if it ever came to that, I would wait till he was out of the house and take the gun. That's a very detailed plan. That worries me. That sounds like the person has thought it through. So that's what you're listening for. If the person, again, even on the second asking, says, no, I don't really have a plan, then, maybe they do, maybe they don't, but they're not telling you, and you've asked them twice, so you can move on. Past behavior, right? The biggest risk factor for future suicide attempt is past suicide attempt. So that's a risk factor. So you want to say, have you ever tried to kill yourself? And you can also ask here, have you ever tried to hurt yourself? Is this, sometimes people do things that are non-suicidal self-injury. And so that's another risk factor. So you want to find out about that. But you can say, have you ever tried to kill yourself? If they say yes, you ask them about it. How did you do it? Did you want to die? So this is where intent comes in. And intent is one of the things you have to ask about. So did you intend to die? So I've asked people who say, yes, I've tried to kill myself. I took pills and then I woke up. Okay. Were you sorry you woke up? Did you think you were not going to wake up? And sometimes they say things like, no, I just really, I was kind of glad that I woke up, or yeah, I was really sorry that I woke up. Again, that's two different presentations. Did they receive medical or psychiatric treatment after this? A lot of people out there have tried to kill themselves and don't tell anybody, right? So you might be the first one talking to them about this. And so they're telling you. And you just remember that in your head, when you're making your judgment, this is a big risk factor. Okay, then we have the symptoms, and they're all listed here. And we have some suggestions about how to ask about these symptoms. So depression. In the past few weeks, have you felt so sad or depressed that it makes it hard to do the things you would like to do? But if you have other questions that you like to ask that assess depression, you can insert your own questions. Again, these are suggestions. So you ask, and when you see later, when Captain Lester shows you the EHR, there's some click boxes, and you can, that's going to help you with your documentation. So anxiety. And you can see by these questions, have you felt so worried that it made it hard to do the things you would like to do, or that you feel constantly agitated or on edge, right? So what you're looking for is, everybody's got anxiety, especially now, right? Everyone's got anxiety. But what you're looking for is where it is impeding function. Like, this person can't really do what they normally do. They can't get out of bed in the morning. They can't do their work. They can't take care of their children because they're so anxious. They don't leave the house. That would be a lot of anxiety, right? So you're looking for something that's more that really stops them from living their life. Are they impulsive and reckless? Our suggestion is, do you often act without thinking? So I'm on impulsivity, recklessness. Do you often act without thinking? Maybe they're speeding in their car where they did it. You're looking for something uncharacteristic, and you're hoping that they can tell you, like, I don't usually act like that, but now I'm acting like this. Hopelessness is a big risk factor for suicide. In the past few weeks, have you felt hopeless, like things would never get better? So you're asking about that. And hedonia, that's a big one too. All of a sudden people lose interest in things that they used to find joy in. So they used to get joy reading or watching a movie or going fishing or taking a hike. And now all of a sudden they don't want to do anything, right? So that's a big risk factor for depression. That's a big sign of depression. That's a big risk factor for suicide. Isolation. Now this does it again. You're looking for something different than baseline. Yeah, all of a sudden you don't want to, there's some people that are just more introverted and don't go out socially. That's not a change. But someone who I used to get together with my friends and now I don't want to leave the house, that's a warning sign. Irritability. This is especially for kids. Sometimes in kids, depression shows up as irritability. Have you felt more grouchy than usual? You can find the way you want to ask that question. And then excessive use of substance or alcohol, where that, are they drinking more? Are they using substances that they didn't used to use before and it's becoming a problem? Their sleep. Can they sleep? Are they sleeping too little or too much? Are they having trouble falling asleep? You're trying to get the pattern here. Appetite. Are they eating too little or too much? Again, I'm looking for the change. Is there a change? And then any other concerns that have there been concerning changing? Okay, now we're getting to the social support and the stressors. So who do they have a trusted person? And for kids, you want to know if they have a trusted adult, because this needs to be an adult that they can talk to. Who is that? And do they have one? And usually it's a protective factor if they have someone they talk to. What are the conflicts at home? Are they a kid and both parents just lost their job? Are they a parent, or even they just lost their job? They're someone, you ask about employment. Do they have a job? And then there's domestic violence. Are you worried that anyone in your life is trying to hurt you? Now, suicide contagion is when people hear about someone dying by suicide and then they copy that. So do you know anyone who has killed themselves or tried to kill themselves? So a lot of times this happens with younger people, that you see suicide in clusters. And it's because maybe somebody's very vulnerable and then they see that someone took their own life and then they think, okay, that's an option. I could do that too. It's a very scary thing. It does happen sometimes. It's happened in different parts of, I believe, on American Indian, Alaska Native populations. And so we have to keep our eye out for that. And then last thing in this section is reasons for living. So people often ask, why do you want to kill yourself, right? That's an important question. But they forget to ask, what are some of the reasons you would not kill yourself? Why do you want to live? That's a really important question, because there's been patients that I've asked that to where they say, I don't know. They can't think of anything. No reason. That's a warning sign, right? But then you might hear, like, I would never leave my children. I just adopted a pet. I would never leave my pet. Like you hear things that sound like protective factors. Okay, so I'm going to move on. Does anyone have any questions about these assessment questions? All right, I'm going to pass this because this is about making a safety plan with a patient. I'm going to pass this because we're going to talk about it again later. But again, what you're trying to get to is one of these boxes, right? So you just asked all those questions, you heard the answers, and now you make a determination. You're going to err on the side of caution, right? But you're going to say, you know what, this really does sound like an emergency. This patient, I think, has current suicidal thoughts. They're thinking about it all the time. They have a detailed plan, and I'm really worried they're going to kill themselves. Or, so that's not the most common outcome, but that is, that's what you're looking for. Or the harder situation is, I'm not sure. They're saying some things that are worrisome, but they also have a lot of protective factors. So I think they need a full evaluation, right? So, and the full evaluation is done from a mental health clinician where they do a full mental health evaluation. The third and fourth categories are, they could benefit from probably some psychotherapy, but this is not urgent and they don't need it right now. And if we don't have the resource for it, we're going to recommend it for another time when there is a resource available, or no further interventions necessary at this time. That can happen when a patient, you're evaluating them for a past suicide history. They've had mental health care and they don't need anything more at this time. Okay. We also, and I'm sorry, this is not updated. We have 988 now that covers both of these, the suicide prevention lifeline, and the crisis text line. So you want to make sure every patient has a 988. Now, I just want to talk about kids. So these are anyone under 18, or I consider a young person and the risk category anyone under 25, but it depends what you consider a youth. So this is where, if you work with children, this is really important. I will tell you that the number one risk factor, the number one stressor on the life scale of stressors, life stressor scale, is losing a child. So having a child that wants to kill themselves is, just off the charts, anxiety provoking for parents, or family members. So you want to bring the parent into this, but you want to do it without making them feel defensive. So even in the nicest way, if you say, did you know about this? Right? That's going to make a parent feel very bad for not knowing about this. So one thing we suggest, and we write it down, is your child said, and you look at the ask questions, your child said they wish they were dead. Is this something they shared with you? If you say it like that, it gives the parent the opportunity to say, no, I didn't know about it. And then you can normalize for the parent that, and this is true, that most parents, even, and it's not because they're a bad parent, it's not because they're not paying attention. Most kids keep these thoughts to themselves. They share it with their friends and they don't tell their parents. So most parents don't know that their kids are thinking about suicide. And that's okay. Now they know. Okay, now you want them to be a safety net for them, right? Then you go through some of these questions. And I'm not going to go through every single one, but one of the things that you want to ask, or two things, is one, are you comfortable? Because now they know they have a child who's thinking of killing themselves. Are you comfortable keeping your child safe at home? And if they say yes, that's what you hope they say. That's less meaningful than if they say no, right? If they say, oh no, I go to work, I'm not going to lock up the firearms, this is a problem. Then you have to pivot and find some other way to keep this child safe. It's also important at the end of the interview to ask the parent or guardian, is there anything you would like to tell me in private? Because you want to give them, you're doing this in front of the child. One of the things I should have said this, before you bring the parent in order to give the child some agency, some control, you want to say to the child, I want to bring your parent in. And the child might say, no, please don't tell my mother, don't tell my father. And you say, you know what, my first priority is keeping you safe. So we need to tell your parent, and I have to tell your parent, but would you like to be in the room, or do you want me to step out and tell your parent? and talk to your parent. And so that's the agency you can give them. But it's also important to ask the parent if there's anything they would like to tell you, because a lot of times people have history of other family members dying by suicide, and they don't want to talk about it in front of the children. Okay, just to summarize, you are doing the brief suicide safety assessment to get to one of these three things. And I'll tell you that the emergency and the low risk are usually very obvious. The harder category is the yellow. It's when you're not quite sure. So this is when it's not an emergency, but the patient does require a full mental health evaluation from a mental health professional as soon as possible. Okay, so I'm gonna stop here. Again, I'm gonna remind you that we screen with the ask, and the screener is probably different than, maybe the same person, but the screener is usually different from the person who's doing the brief suicide safety assessment. You might say to me, how am I going to do what you just said in 10 minutes, 15 minutes? I'm telling you that it should not be an hour. It should not be a half hour, because what you're doing is you're asking those questions not to come up with a formula, but to help you make a clinical judgment. What does this patient need next? Okay, so now we're going to show you how that happens, and I'm going to pass the baton to Debbie Synder, who's going to walk you through some of these examples. Okay, Debbie?
Can't hear you.
Debbie, we can't hear you. And you're also welcome to come in here if that's not working. I really apologize for all these glitches. In person is so much better.
Looks like I'm talking,
sorry.
but
Oh, okay, I can hear you now.
oh, you can.
Oh,
Okay, yeah. Okay. So let's go to the next slide then, Elisa, if you don't mind. So this part is going to be very interesting, because we're going to share some videos with you, which will really help to bring the BSSA to light. So I just want to tee up the video by telling you a little bit about the case example. So this is going to be interviewing Priya, who is a 29-year-old with a young woman with an ACL tear, who it is non-acute positive, as you can see by the ask. If you click through that, Lisa, you'll see she answers no to the first question: in the past few weeks, have you wished you were dead? No to the second question: in the past few weeks, have you felt that you or your family would be better off if you were dead? No, in the past week, have you been having thoughts of killing yourself? But yes, have you ever tried to kill yourself? Which, as Lisa mentioned, is the most common way to present. And then no to the fifth question: are you having thoughts of killing yourself right now? So this is a non-acute positive. And we want to show you how the BSSA can really be done in 10 minutes, 15 minutes. And remember to highlight that it's not a full mental health evaluation. And it really is supposed to tee up, what we're supposed to do in terms of the disposition, what should happen next. So why don't we go to the video, which is the next slide. Yeah, and we'll listen to this together. It's about 7 minutes long.
Hi, I'm Miss Davis. I'm a social worker here in the hospital. It's nice to meet you. I see you are here for an ACL tear on the right knee. Yes. How are you feeling today? At surgery, looks like 2 days ago. Yeah, no, I feel so much better. Great. So glad. I'm so glad. Well, I'm here to follow up on a bunch of screening questions that I think the nurses asked you when you first came, which you might remember about the mental health questions related to suicide. Yeah. Is it okay if we talk now for a few minutes? Yeah, we can talk. Great. So I'm just looking over the screening tool here. It looks like of the 4 questions that they asked, you answered yes to have you ever tried to kill yourself in the past. And I just wanted to follow up with asking you a little bit more about what happened.
Yeah, so I was 17. I was a junior in high school. And I just had a really rough year that year. I was just going through a lot. My boyfriend at that time. I was just going through a lot. I felt really isolated. Like, really, I remember there were days where I couldn't get out of bed. So I think one of the nights, in the middle of the night, I woke up and I went to the kitchen and I grabbed a knife. And then I think my mom heard some voices and came down and like stopped me. So yeah, that.
And can you tell me a little bit about what you did with that knife?
Yeah, so I think what I was trying to do is I was just like taking the knife and cutting my wrist and trying to like harm myself and yeah.
And do you recall at the time if you had an intent to die?
Yeah, I think I just didn't want to die.
And have you had any, prior to that, did you have any diagnosis of any kind of depression or anxiety?
No, I've kind of been an anxious person. Like I worry about things, but nothing significant.
And were there any previous attempts prior to that?
No,
Wanting to end your life?
no, that was just
Okay. So if you could tell me a little bit about whether you sought out any treatment after that, did you see mental health professional, a therapist, a psychiatrist, nurse practitioner, anybody for medication?
yeah. So after that, my parents and I had a conversation, and I started therapy soon after that. So I was in therapy for.
Okay, and how was that? What was that like?
I think it was great. It was really good. It really like taught me how to like manage my emotions, manage my stress. So it was really good.
Okay. And did you take any medicines at the same time for the depression or the worry?
No, it was just therapy, like one.
That's great. Therapy can be effective for kind of teaching coping strategies to try to understand what triggers things at play. So since that time at the age of 17, it looks like you're 29, is that right? In the last 12 years, to what extent have you had any sort of episodes of severe anxiety or depression that's gotten in the way of functioning to the point where you didn't want to live anymore, that got as bad as it did?
No, nothing like that.
And I don't know if they talked with you at all about safety planning. Is that something that's familiar to you? The language that's often used in mental health.
Yeah, I think that my therapist and I talked about it.
Do you remember what you learned at the time?
Yeah, I think it was about like, oh, what would I do if I had those thoughts again?
Tell me a little bit about what ideas you have in mind in terms of a plan for safety for you.
Yeah, I think whenever I have a stressful time in my life in general, I talk to my best friend. Sometimes I just like to journal, so things like that.
Yeah, that's great. So really important in terms of a specific plan for you that the center what guides this notion of a safety plan. The other thing we'd like to talk about a little bit are sort of reasons for living. So tell me a little bit more so I can understand, you know, what reasons do you have to choose life at this time?
No, I think life has been really good. I really like, I started a new job recently and I've been really enjoying it. And I think I have like, I'm close to my family. I have like really close friends. And
That's great. But that all sounds wonderful. So let me ask you this question. If the thoughts were to return, because it's not unusual for someone's got a history of feeling worried, that sometimes the worry recurs or can be triggered by things. If those thoughts came back and that sadness came back to the extent that you felt like you needed help, what would you do at that point?
yeah, so I know that my work, like they have some counseling programs for employees.
Right.
So I would go and sign up for that. Yeah.
Okay, like an employee assistance
Yes,
program.
yes.
Okay, can you think of any other ways that you might go out and get help?
I think, as I mentioned, I would talk to my best friend.
Great, great. So also just so you know, I mean, I'm only here to treat your knee, and so I don't expect to see you much beyond this ACL tear, but primary care physicians are around, and when you go in, or if you need to go in, mental health issues can be addressed there. There is also, obviously therapists and psychiatrists that are available, and you can look in network. And then sort of short of that, I'd like to tell people, and I tell this to everybody, about the 988 number. It's a national suicide prevention lifeline. They've been around a really long time. They're staffed by volunteers 24/7. So they've got someone at the ready, whether you want to talk on the phone or just text with them. It's 988 is the number. And I really encourage people to put that in their phones. And if everybody that I talk to, just to have available, because you never know if thoughts come back sometime in the middle of the night. You're not sure who to disturb. That's a good place to start in terms of having someone to talk to immediately, kind of work through what might be going on. Are those things that you think that you would be amenable to doing?
Yeah, definitely. And that's really good.
Great. I guess the only other thing I wanted to end with is that so if you ever come back to the hospital here, we're really trying to take all of this seriously at the Institute and implement kind of a prevention or preventative approach to managing suicide. So these questions may come up again. And I just want you to be aware that if that happens and we feel like you need to talk with somebody again, or you want to talk with someone again, we're around and have staff available for that. Yeah, do you have any other questions for me?
No, that sounds good.
Yeah, great. Well, thanks for taking the time and being so open with me today. And good luck with that ACL repair.
Thank you.
Okay.
So I hope you were all able to hear that. I think you were. I just want to can you hear me now?
Yes.
Are you okay?
Yes.
Thank you. Thank you. I just want to highlight a few things. You saw how in a very short period of time, that took 7 minutes. I was able to talk with Priya about this episode that happened when she was 17. So that was 12 years prior. She's now 29, and got her to expound upon that a little bit, that she was having trouble in the middle of the night, woke up and grabbed that kitchen knife, and her mother intervened. And then we got into a conversation about, what she did thereafter. She talked about talking to her parents, getting into therapy, no medication at the time, and learning coping strategies that had really helped her in the interim 12 years. And then I asked a question about, I think it was sort of to what extent has she in that time frame experienced any severe anxiety or depression that's been so bad that it's interfered in her functioning and her not wanting to live. So it's a very structured, specific question. And she said that she really hadn't had that experience in the interim 12 years. But even still, you see, we went on to do safety planning, which she had learned in therapy a little bit. I got her to review that. What would happen if if those thoughts did come back? What would she do about that? She would call a friend, she would journal. And then we went through reasons for living. As Lisa said, that's an important component to ask about as well. She started a job that she really liked, and she had close friends that she enjoyed engaging with, and then talked about how she could go to EAP in her employee assistance program in her current place of employment. And then we went through the safety planning and resources, including the 988 number. So you see how in a very short period of time, we were really able to hone in on in terms of that brief suicide safety assessment, making a determination about what should happen next, and deciding that she didn't need any additional treatment. And then at the last piece about since that last visit, I did a little education about if she was going to be coming through our institution again, that she might get asked these questions, and we were going to ask her since the last visit, had she had any of these questions again, just to sort of tee her up in case that happened again, and to let her know we would be here for her if indeed those thoughts did come up again. We would be here for her as well. So let's go to the next example, which I think is the next slide. And I think before this, yeah, there we go. So this is a case example of a child, so youth under the age of 18. This is Ryan, who's 17, and is going to come up as a Q positive on the ask. So you'll see he answers yes to the first question. In the past few weeks, have you wished you were dead? He answers no to the second question. In the past few weeks, have you felt that you or your family would be better off if you were dead? He answers yes to the third question. In the past week, have you been having thoughts about killing yourself? And then no to the past question, have you ever tried to kill yourself? And then with regard to that fifth question, are you having thoughts of killing yourself right now? He answers yes. So this is an acute positive. And I want to show you what this brief suicide safety assessment, this BSA, looked like next. So let's get to that video.
Okay, I will just say this one was done during COVID, so it is done via Zoom, but picture them in the same room together.
Right, and this was actually done by a pediatrician, and it's about 6 minutes long, so you'll see how that goes.
Hey, Ryan, how are you doing?
Okay, how are you?
I'm all right. It's been a busy day. Hey, your mom called earlier and left me a message that she was worried about you and said that you've been really tired, and I think she even thought you might have mono. And so I'm glad that you came in. I know you were trying to go to school today, that you missed some school because you haven't felt very good, she said. And, you know, my nurse said, gosh, Ryan just doesn't look like himself. And I think she had you fill out a couple forms. And we can certainly check a mono test, but there were some things that you answered, and I kind of need to ask you some questions about that. Would that be okay?
Sure.
Yeah. Boy, it sounds like things are not going too well right now. You're not feeling good. Is that right?
Yeah, no, I don't feel good at all.
Yeah. So it looks like on this one screen, it's a screen for depression, and boy, your numbers are pretty high. What's going on?
Yeah, I got caught at a party the other night, drinking, and I'm supposed to go to college next year on a scholarship, and I think they might pull me. So I've been pretty upset about that recently.
Wow, I can see where that would be. That's a really big deal, isn't it?
I don't know. It just seems like my life's over now.
Yeah. Did you talk to your folks about that?
A little bit. They're pretty upset with me. They see it. I made a stupid mistake or something.
Yeah. It sounds like to you this is a really big deal.
I'm really excited about college and graduating, but I don't know. It doesn't seem like that's going to happen anymore.
And you said, I just heard you say, I feel like my life's over or might be over.
Yeah, I mean, if I don't go to college, like what am I going to do?
Right. Well, I noticed on this other questionnaire, you said you've been having some thoughts about killing yourself. Can you tell me about that?
Yeah, I mean, like I said, if I don't go to college, like what's the point? So I'd rather just be dead.
Yeah. And are you having those thoughts right now? Have you thought about how you might do that?
Yeah, my mom keeps a gun in their nightstand. I think I'd use that.
Okay. Yeah, and have you talked at all about any of these feelings with your mom or dad?
No, I don't think they get it. They're just really mad at me right now.
They're mad at you. Yeah. Have you ever tried to kill yourself before? No. Okay. So I'm really concerned about what you've just shared with me, and I'm so glad that you did. You and I have known each other a long time, and I don't want anything bad to happen to you. Can you tell me a little bit about how likely are you to kill yourself with a gun?
Really likely. I mean, I think I'd do it when my mom and grandma are out at church. Everybody's out of the house. It doesn't look for them, so I could get it pretty easy.
Okay. So you've been thinking about this a lot. It's really top of mind. Yeah, I'm sorry. That must be really scary. Yeah.
But you can't go to college.
Well, I can see that, it really feels like you feel hopeless maybe, and it sounds like some, just almost doesn't feel like there's any way out. And I'm really concerned because I want you to be safe, and I don't want you to die. And I think it's really important that we kind of try and get some more help for you. And what I'd really like to do is to call your mom and see if she could meet us here.
And in the meantime, if it's okay, I thought maybe I'd just have somebody sit with you for a little bit. But I think it might be important for us to, for me to have someone who's really skilled at asking some questions, because I want to make sure that that you're as safe as possible. So I'm going to need to call her. Okay.
Yeah, that's okay.
Okay. Okay. Well, listen, I'm going to just have Sarah come and sit with you for a little bit right now, and then I'll give your mom a call, and we'll wait for her to come. And when she gets here, we'll just go over plans. Probably we'll need to send you to the emergency room today because they have staff that are really good about figuring out what's the best way to keep you safe. Okay. Thank you again for sharing this with me. I know this is probably really, really tough. And I'm worried about you.
So this is a hard case to hear, but a really important one of a young man who is acutely suicidal. We talk about how Lisa said the easy cases are easy, although nothing about this is easy, but this one was pretty clear that he's in acute risk, as you heard the pediatrician asking the story. And imagine, again, it was in person and not over the phone. She's, started with, Mom said you were tired. By the way, it's not uncommon, particularly in kids, for them to present with somatic symptoms or somatic complaints, a belly ache, they're fatigued, they have a headache, but you can see how that gets turned into, a potential marker for some depression. And in his case, the pediatrician picked up on this depression. And then he opened up about his story that he was caught drinking and lost a scholarship for college. And he was just distraught and devastated about this for obvious reasons. And there was a struggle between him and his parents. We heard a little bit about how he was having trouble talking with them about this. And when the pediatrician then went a little bit further to dig a little bit more on the story, found that there was access to lethal means to this gun by the nightstand, and he knew it was there and had access to it, and it just didn't seem like there was anything that was keeping him from killing himself. She tried many different ways. She's very empathic, you heard, and how she was very supportive in terms of him being honest and open with her and directly talking with her about this. And she was able to elicit his helplessness and his hopelessness, and just feeling in a bind, like there was no way out. And we know, of course, when people are feeling in a bind, particularly kids, where there's sort of lack of autonomy and lack of independence and full agency, you can feel even more stuck. And at that moment, it was pretty clear that she needed to keep him safe by doing two things: by calling Sarah, this nurse, into the room to sit with him while she got on the phone and called his parent to then take him to the emergency department, where he would then have a full mental health evaluation done. So again, this was 6 minutes. There was a lot that happened in that 6 minutes. It was done very, very professionally, so that then she made the determination on that disposition that a full mental health evaluation needed to happen urgently because it was an acute situation. And now let's go to the third and last video, if you would, Lisa. Well, before we get there, let me tee that up. This is the example of—
Actually, Deb, before you
yes.
do, I just want to insert one thing in this.
Oh, sure.
This actually was based on a real case. Something like this really happened, and a nurse had saved this kid's life because they were only screening on well visits, and he was brought in for worry about mono. I mean, he's an actor, but it was based on a real case. And the nurse just had a bad feeling about him, like that she was worried. So they screened him, even though they weren't supposed to. And I always use this as the best example of why universal screening is so important. Because had this nurse not had that bad feeling and screened him, all this would never have been picked up. So I'd like to just drive that home. And, nurses save the day all the time, but no one should have to rely on intuition. And that's why we're doing universal screening. Okay.
Yeah. So the third example is Emma, and this is an interesting example. Emma's played here again by one of the actors, a 34-year-old who comes up acute positive on the ask screen. And then when the BSSA occurs, it turns out really is a non-acute. So it's sort of interesting, right? So in terms of the first question, that's a yes. In the past few weeks, have you wished you were dead? Emma says yes to that. And the second question, in the past few weeks, have you felt that you or your family would be better off if you were dead? She says yes to that, then says no to the subsequent two questions. In the past week, have you been having thoughts about killing yourself? No. Have you ever tried to kill yourself? That past behavior question, no. And then answers yes to the acuity question, that fifth question, are you having thoughts of killing yourself right now? So when the clinician came in to do that evaluation, came in assuming that it was an acute positive. And I want to show you how this one turned out.
Okay. Hi, Emma. I'm Dr. Patel. I'm a psychiatrist here at the hospital. And as you know, we are going to talk today about a recent screening questions about suicide that you had filled out. Mm-hmm. And my understanding is in that screener you had mentioned some thoughts about having some suicidal thoughts. And so we're going to talk about that a little bit today.
Okay.
So I appreciate that you, I know these things are really difficult to talk about, and, we very much appreciate that you are open and candid and shared these thoughts with us.
Absolutely.
So thank you for that.
Mm-hmm.
So I'm going to ask you a few questions. If you could just tell me a little bit about those suicidal thoughts that you were having.
Yeah, so last year I went through treatment for ovarian cancer, and it was brutal, and it was really hard to get through. And I was in remission for a bit, and now I just got the diagnosis that my cancer has come back, and just the thought of having to go through the treatment again, I've just been feeling like I would rather be dead and not go through this again.
Okay, I'm sorry to hear that. So you've decided that you're going to go through with the treatment?
I am going to go through with the treatment.
Okay,
Mm-hmm.
okay. But with that is coming these thoughts of, I guess, feeling overwhelmed and
Yeah.
wishing you were dead.
Definitely, and I feel I have a young daughter
Mhm.
and a partner, and I feel like my going through treatment is definitely a burden on my family. So
Mhm.
that's where some of those thoughts have been coming from.
Okay. And how long have you been feeling this way?
Probably been feeling this way the last few weeks.
Mhm.
I did experience this a little bit during my first treatment, but it wasn't as bad as what I'm feeling right now.
Okay. And at that time, did you seek help? How did you process through those feelings?
Yeah, I kind of just turned to the support system that I have within my family. I'm really close with my sister and my husband. So I kind of just talked to them. I didn't seek any professional help.
Mm-hmm.
But I did in college go through a period of depression where I did seek professional help, and I was seeing a psychiatrist and a therapist at that time.
I see.
But I'm no longer seeing them.
Okay. And in that period of time when you were younger and in college, did you have suicidal thoughts then?
No, I never had suicidal thoughts in
Mhm.
college. It was just feeling really down and having a hard time getting through my days and getting out of bed in the morning.
Okay. And moving back into what's happening now, so this has been going on now for a couple of weeks, and can you tell me a little bit more about the thoughts? Was it just thoughts of wishing you were dead, or were they thoughts that I want to kill myself, I want to take my own life?
I think there were more thoughts of wishing that I was dead,
Mhm.
anticipating going through this really hard and long treatment again. Just made me think that I would just be better off it would be better for my family, and I would just be better off dead.
Mhm.
But no thoughts of actively wanting to kill myself.
Okay. And have you ever, in these last few weeks, have you had any thoughts, if not today and in other times during these last 2 weeks, of wanting to kill yourself?
I don't think so. I think just thoughts of wishing I was dead.
Okay. Okay. Have you had any thoughts of maybe not if I want to kill myself, but if I were going to kill myself, this is how I would do it? Any planning to that end?
No, I've actually never thought about it that
Mhm.
way.
Okay.
I've never thought of how I would do it.
Okay, all right, well, that's good. And in terms of, you mentioned that this has happened to you before and that you became very despondent and distressed with the first time when you were diagnosed with ovarian cancer, and at that time you had those thoughts, and in that period, did you ever make attempts or even thought in your mind, this is how I would kill myself?
No, I never did.
You've never done that?
No.
Okay, all right. Let's move on into other symptoms. Sometimes when people have these thoughts of wishing they were dead, it's an indicator that your mood might not be well. You might be overwhelmed with the situation, which it sounds like. So tell me a little bit about depression. Do you think these days that you do have depression?
Yeah, I think I do. I think it's been really hard to get up in the morning and do the things that I normally do. I've had a really hard time finding the energy to play with my daughter, to go to work. So I've just felt generally really down lately.
Okay. Have you been going to work?
I have been going to work, but I have to stop going to work as I start my treatment.
Okay.
But I'm a teacher, so it's been very difficult to find that same energy to work with the kids and to get through the day. So.
Okay. And in terms of feeling hope or not feeling hope about your future, about this next round of treatment that you're going to start, do you have hope? Or
I do have a little hope. I think I have to have hope for my family, and I do want to go through with treatment. And I think that I went through it once and it worked for a bit, so hopefully this time it works and I'm cancer free.
great. And tell me about substance use. It's something that we frequently ask about. How often do you have a drink, an alcoholic drink?
Not often, maybe once a week, once every couple of weeks.
Okay. And have you ever had a problem with thinking that you were drinking too much, or maybe an addiction of any kind?
Nope.
Okay. What about illicit substances or drugs, recreational drugs, marijuana?
Nope.
Any other drugs that you use? Okay. All right. And then tell me about your sleep. How has that been?
My sleep has been okay. I feel very tired a lot, so I think I'm sleeping a lot more than
I see.
normal because I'm so tired, and it is tricky for me to fall asleep, but I think once I do, it's hard for me to get out of bed
I see.
in the morning. So
Okay. All right. And how about your appetite?
my appetite is definitely not typical. I'm finding it very hard to eat. It's kind of hard to tell if it's mood-based or if it's my treatment, but I think it's been tricky to eat lately. So.
Okay. All right. And you've told me a little bit about yourself. So you are 35 and married with one daughter. Is she your only pregnancy?
Yes.
Okay. And she's generally healthy?
Yes.
Okay. And who else is in your support network, if anybody else?
Yeah, I'm very close with both of my parents and my sister, and I have some friends at work that I'm also very close with.
Okay. All right. And did your parents and sister live locally? Do they live
They
far
do.
away?
They
do.
live locally.
Okay. And you guys are in touch?
Mm-hmm.
Okay. All right. Have you shared with them ever about your depression, or that you go, what you're going through?
I don't think I've shared the extent of the feelings I've had, but they do know that I've experienced some bouts of depression.
I see. Okay. And tell me, just in general, when you think about, and I think you've already mentioned some of it before, but what kind of keeps you going? What makes you, even though you're having feelings of depression and fatigue, what gets you out of bed and keeps you going?
Yeah, I think my daughter definitely is one of my biggest motivators to get up and get out of bed. Spending time with my partner, when I can work, the kids at work definitely are big parts of my life. So those are all things that keep me going.
Great. Okay. So I think at this point, it makes sense to talk about what we refer to as a safety plan. In the event that those thoughts go from just wishing that you were dead, which is, of course, it's a sign of depression, and I would say that those are serious thoughts in need of intervention, I think. But if we just stick to the part of, if you have the thoughts and should they get worse, and they start moving into thoughts of not just wishing you were dead, but actually you now start thinking about maybe I should be dead, or maybe you start thinking of ways to harm yourself. That can happen to people, and so to create a safety plan around that if that were to happen, what could you do and what will you do to prevent yourself from harming yourself? Mm-hmm. So what do you think, like let's just pretend that the thoughts became more intense and they're not going away after a day or two, and you're now actually thinking about a plan to do something. What could you do to prevent yourself?
Yeah, I would definitely tell my husband right away.
Mm-hmm.
And if not him, maybe my sister.
Okay.
So I would definitely talk to someone and reach out to someone.
Okay. And that would be very important, to reach out to someone in your support network for help. Mm-hmm. And help for this can come in a variety of different ways. One very quick and easily accessible way to get help is, I don't know if you're aware of the Suicide Warm Line, mm-hmm. But it's, you basically on any phone can dial 988 and you will get a live person on the phone who is trained and in a very confidential manner can talk to you about your feelings and just sort of work through them. Mm-hmm. And this can be a very effective way to help the thoughts come into control.
Mm-hmm. That's good to know.
Yeah, so that's definitely a thing you can do. And another time when things become very intense and you feel like you're still not in control of them, you could always reach out to medical providers. And that often comes in the form, if they're very serious thoughts and you feel like you're not able to control them, you could go to a local emergency room. You can always reach out to your primary care doctor, but reach out to medical professionals if it were to get in a situation where you feel you're not able to control it anymore.
Okay.
But I think these are all good strategies,
Mm-hmm.
Should we get to that place.
Mm-hmm.
So I think the next steps would be to also focus on the depression, because often when we treat depression or mood problems, these wishes and thoughts of death go away with that. And so would you be open to getting
Absolutely.
additional help?
Mm-hmm.
I think what would make sense, and it seems like you've done this already, so you may be familiar with this. Back in college, you said that you had taken medications under care of a psychiatrist and saw a therapist. I think it might not be a bad idea for you to reach out and start therapy for a number of reasons, to help with these thoughts, but also to just have that added support and treatment intervention as you go through your cancer treatment.
Okay.
So I think seeking out therapy within the next week, is that something you know how to do? Would you know how to go about finding a therapist?
Yeah, I think I can definitely go through work too. They have a lot of resources for me to find mental health care. So I think I can do that. Yeah.
Okay. And if you have trouble with that, you can always reach out back to us and we can give you referrals. You can also contact your insurance company. They can give you names of local providers for therapy. So if we could get that started in the next week, that would be great.
Okay.
And in addition, sometimes for depression, if we feel like this is something where you want to consult with a psychiatrist just to see, is this an appropriate time to start a medication? That's also something that might not be a bad idea to get a consultation with a psychiatrist.
Okay,
Great. All right. Any questions for me? Anything else we can talk about?
No, I don't think so. This has been very helpful.
Thank you.
I'll just kind of do a recap of what we heard there. The clinician is on the left with the dark hair, and then of course this patient on the right, that's Emma, who's a 34-year-old with with ovarian cancer. This is a recurrence of her diagnosis, and she is really struggling with mood symptoms. And what the clinician did there was really try to tease out to what extent her thoughts were more active or passive in terms of wanting to die and wanting to kill herself. And in the questioning, which is going to go on a little bit longer because it was an acute positive. So this clinician is digging a little bit deeper than we did in the other videos, just to kind of go at it from a variety of different directions. And these are the things that Lisa highlighted earlier on that BSSA, where we go into more in depth in that section around asking about symptoms, depression, sleep, irritability, alcohol and drugs. And so the clinician kind of goes into more depth about that, asks about to what extent she's drinking or using recreational drugs. She says no to that. She asks to what extent she's kind of really depressed and despondent about this recurrence, to which she says she is depressed and that the recurrence is hitting hard. She asks about the support system. She describes she's got a lot of support from her husband and friends, and she really wants to live for this daughter and her husband. She doesn't have a particular and specific plan. She's really just feeling very overwhelmed. And she gets at some degree of hope, which she has because she had a positive response for the first treatment. She knows what to expect in terms of cancer treatment, and this gives her some hope in terms of what to expect that this second go around, and doesn't have again, and you see this clinician trying to get a little bit at what are her mood symptoms like? Is she sleeping? She talks about how she actually is sleeping at night, and then so she's sort of teasing a little bit out to what extent is this more of a depression talking here than perhaps active thoughts of suicide. So she does a very nice job of that. Again, is empathic, makes comments about how it's wonderful that she's being open and talking directly about this, and then goes on to do some safety planning. What would she do if these thoughts came back? And was she aware of the 988 number, which we have everyone put in their phone? That's the National Suicide Lifeline prevention number. And then she talks with the patient about how it's very possible, it sounds like she's depressed, and really she's recommending that she go on and meet with a therapist, a counselor, to consider doing some talk therapy, and maybe even to consider medication. So she's kind of wrapping that up right there in the session. So turns out this is an example of someone who looked like they were an acute positive based on answering yes to Q5. But then when the clinician went in and did more of an evaluation in 10 to 13 minute period of time, was able to determine that in fact she wasn't an acute positive, and was able to kind of wrap it up and make some recommendations going out. And I think before I pass it along, and I know there was some glitches in the video there, but if you've got questions about these, you're welcome to throw those in the chat. I'm happy to answer those, and Lisa is as well, if there's particular comments or questions. If not, we can kind of go to the next step, which is a little bit about our section on documentation with regard to the brief suicide safety assessment. So I'll just give a minute for anybody to chat in there and keep an eye on that. But as I'm doing that, I can focus in on this slide here. So in terms of documentation, it's very important to throw into the documentation which questions are positive. So you can actually write down, patient said yes to the question, and you could actually repeat what the question is so that it's identified, and then comment about to what extent it was an acute versus a non-acute screen. And then you want to clarify in that documentation again whether there is any active or passive suicidal ideation. So is the patient just feeling overwhelmed and wanting to kind of die because they're in pain, or because they're worried about this recurrence and what this might mean in terms of their mortality and future? In the case of Emma, she really wanted to live. She was choosing to go for another round of chemo, but was really overwhelmed with what that experience was going to be like. So she denied, in that example, a current intent to die, and we'd want to write that in the documentation. In addition, we want to highlight the risk and protective factors. So in this case, she did not have any past suicide attempts. If you've elicited any family history in your evaluation, in your assessment, you could comment about that. If you elicit information about pain being connected to experiences of wanting to die, you could talk about that specifically in that documentation. With regard to protective factors, we talk about the kinds of support they have, who in their life. Explicitly, in the case of Emma, this was her spouse. In the case of our 17-year-old, there was no protective factors. There was nobody he was talking to. There was a break between he and his parents, who were really upset that he'd lost that scholarship. So you want to be very specific about the risk and supportive factors. And then we want to document more about the specific safety plan that we've discussed with the patient before you. So in the case of Emma, the safety plan would be getting in touch with her spouse and contacting 988. And in the case of Priya, similar things. She liked to journal, contact friends. She knew how to contact a therapist and the 988 number in terms of what to do if the suicidality returned. And you want to go very explicitly and specifically at that in the documentation. What you don't want to include in the documentation is a statement about contracting for safety. This is something that mental health professionals used to recommend in the past decades, that if somehow we had them sign a contract, if we had patients sign a contract, that means they wouldn't go on to kill themselves. We know that it's more important to know that if you can't elicit that they've got a safety plan, then we're more concerned about what we need to do about that. So we want you to document is that the patient is at no risk for suicide, is at slightly elevated risk for suicide, and it's important to use the word suicide directly. Don't leave that word out by using just indirect words like self-harm or hurting. We want to use specifically the language that you've elicited in that assessment that the patient has used directly with you.
So there are 3 things that everybody can do that makes a difference. And so I don't want you to feel like we're screening and then maybe you're even assessing and then there's nothing to do, because these 3 things really can help somebody. So the safety planning, the lethal means safety counseling, and providing 988. Though just those 3 things alone could be an intervention that saves somebody's life. Okay, so just the safety plan, if you are going to make a safety plan, you can take a full training on how to make a safety plan. So I'm going to do this very quickly, and it's not necessarily will be sufficient, but I just want to tell you, Debbie talked a little bit about this. Dr. Patel in the video talked a little bit about this, but what you want to do is you want to have these things be initiated from the patient, right? So you say to them, what are your warning signs that make you think about suicide? What are your triggers? So they might say, every time I have a fight with my spouse, I feel like killing myself. Or a child might say, every time my parents fight, I feel like killing myself. Or every time my ex-girlfriend texts me, I feel like killing myself. Those are all warning signs. Then you go over and you say, what are 3 things you can do to help distract you away from those very painful thoughts? And they can say, and you can suggest things, but first you see what they come up with. Can they listen to music? Do they like to watch TV or a movie? Can they write in a journal? Can they do exercise? Can they call a friend? Can they spend time with their pet? Whatever it is for them, it's personal to them. What helps you through really hard times? And you have them write down 3 things. And then there's social contacts and support. Who is in your life that you can reach out to when you're not feeling well, so that you can have some contact and you don't feel so isolated and alone. And then who are your emergency contacts? If it's 2 a.m, who are you going to call? And, the 988 is definitely one of those things, but who are your emergency contacts? And then reducing access to lethal means is so important, right? Because when someone's in a suicidal state, they're in a state of unbearable pain. And sometimes they can do something in that state. Their brains are not functioning well. They are not using good cognition. They're not thinking clearly. And if something is around, they can harm themselves. And I can't tell you how many patients I've assessed where they said, I almost killed myself. And I say, what happened? They say, well, my cousin walked in the room, or my mother called on the phone, and it distracted them away. But, the best example of reducing access to lethal means is the nets under bridges. People, critics of that will say, well, if someone wants to die by suicide and they pull up to a bridge and they're planning to jump off and there's a net, they'll just find another bridge. Well, that research shows that is not true. You thwarting someone's plan by reducing access to lethal means can save their life. And so a lot of times, and especially parents, don't think about all the pills they have in their medicine cabinet, even over the counter, like Tylenol or Advil, or having firearms. And, you don't have to remove them from the house. They need to be safely stored if someone doesn't want to remove them. And also with the lethal means, we don't even ask anymore, do you have a gun in the house? We don't ask. We assume they have a gun in the house. We tell them how to store a firearm safely, store the bullets and the firearms separately, make sure they're locked, make sure people who are at risk don't have access to those things. And then providing resources like 988 or the crisis tech line, the Veterans Crisis Line. There are some communities that even have access to a native suicide lifeline. Is that right, Dr. Endecorn? Maybe not in Nashville. Okay, so to summarize, suicide risk screening, universal, which means we're asking everybody. That's an opportunity to start a very difficult but very critical conversation that can save someone's life. And even though this language is very blunt, it's so important to ask directly, right? Because that shows the person that you can handle this. You're asking directly. You're going to brace for the answer, right? That no answer is important to brace for. And then it's crucial to further triage the screen with what we went over today, these brief suicide safety assessments, because that helps you not treat everybody uniformly. Like it's no one size fits all here. You saw that example of the acute positive that wasn't really an acute positive. She did not need to go to the emergency department. And that was better for the patient and it was better for the emergency department, right? So this BSSA is so critical to help make a judgment about next steps. And again, the 3-tiered pathway is the brief screen, the BSSA, and then what does the patient need next? And then the 3 things that can make a difference: the safety planning, the lethal means safety counseling, and 988.